that as well. Also, the meeting is being recorded. So a little bit of history for those who are new to us. Although we started off as a national organisation for hypoparathyroidism, we've been supporting people with primary hyperparathyroidism for a long time now online and via our helpline. And we found that while hyperpara was much discussed at conferences and appeared to be better known and better understood than hyperparathyroidism, we were nevertheless being approached by patients who had nowhere else to turn and had found us online. So we felt we had to respond. We rebranded what had been Hypopara UK since 2005 and became Parathyroid UK in order to properly reflect the work that we've been doing and support the patients of both conditions. And this made sense to become the charity for the whole parathyroid gland, especially as our advisors already saw patients of both conditions. We wrote the first patient information leaflet on primary hyperparathyroidism in 2017, which was highly commended by the BMA, and we were represented on the NICE Hyperpara Guidelines Committee in 2019. Since then, our membership has increased to nearly 5,000, with 40% of those now being patients with primary hyperpara. And our support group, busy on a daily basis and run by expert patients, now has nearly 1,000 members. And I think these numbers are an indication of how challenging and distressing this condition can be. Even those that are straightforwardly diagnosed and managed and have successful operations can be stressful, and others, of course, don't have those things, and demands from patients for emotional support, practical advice, and reliable information is very high. Our patient support groups open 24 hours a day for this reason, and it fulfills a great need. We also work very closely with our advisors to raise awareness about the true impact of hyperpara and the very real level of unmet need. Our medical advisors are the most experienced in their field, and we're very proud to work with them. They educate and examine trainees, raise awareness, hold workshops at conferences around the world, and carry out research to further understanding and help improve patients' lives. So tonight we are honoured to have consultant surgeons Mr. Radu Mihai from Oxford, President of Bates, and Professor Saba Balsubramanian from Sheffield, Research Lead at Bates, and Professor Rachel Crowley, Consultant Endocrinologist in Dublin and a Clinical Professor at University College. I'm delighted to welcome them all here. So without further ado, I'll hand over to our first speaker, Professor Crowley. Thank you.
Thanks very much, Liz, for the nice introduction. And thanks to Helen, who's going to be sharing my slides with you. So if it all looks a little bit klutzy because I'm telling Helen to move them on, please be patient with me. I am, as Liz said, a consultant endocrinologist in Dublin in Ireland, and I see lots of patients with varying degrees and presentations with hyperpara. So I'm going to share some of the insights and some of the things that we're thinking about with you all. And we're very conscious that there are going to be people on this meeting who are just coming to terms with a new diagnosis and don't know a whole lot about this, and other people who've done a lot of research and discussed this with a lot of experts already. And so what I'm talking about may be a bit complicated for some people and not detailed enough for others, but we'll see how we can manage that through in the chat. So Helen, if you can move on to this slide. Thanks very much. The point of this slide isn't to scare people, but it's just to acknowledge that there are a lot of associations with primary hyperparathyroidism that mean that it's worth exploring this diagnosis and trying to resolve it for patients who are living with it. So mortality is the word that doctors use for the association of an increased risk of death with a condition. And so there is an association of a slightly higher mortality with the diagnosis of mild hyperparathyroidism, but nobody knows if this is caused by it or it's just an association, because we're more likely to diagnose hyperpara in patients that are living with other diseases and are having a lot of contacts with doctors. There is thought to be an increased risk of death from cardiovascular causes and from cancers with hyperpara, and that's what the left part of this slide is. And then on the right part, it's showing morbidity. So this is the word that doctors use to describe illnesses that are associated with a diagnosis of hyperpara. And they made the attempt in this paper, which is from a UK group, to adjust for other conditions. So if the patient already had a diagnosis of a particular illness, that should be in some way covered in the way they did their analysis. So patients with a diagnosis of hyperpara seem to be living with cardiovascular disease, particularly irregular heartbeats, that's arrhythmias, and cerebrovascular disease, so that's strokes and mini strokes or TIAs, and renal failure. So every patient who's been followed up for a while with hyperpara knows that the doctors are checking out their kidney function, and that's for this association, and renal stones. And not all patients with renal stones get into kidney function problems and vice versa. So you have to look out for those things separately. And psychiatric association. So patients often describe problems with their mood when they're living with hyperpara. And this can range from just feeling a little bit low and not yourself and fatigued, right up to very severe experiences of depression and even psychosis. So it is a diagnosis that psychiatrists and medicine for the elderly doctors look for a lot in patients who seem to have those kind of mood problems. Unfortunately, in patients living with those kind of severe conditions, it's not often hyperpara is the underlying cause. But high blood pressure, hypertension runs with it. You're all aware that we're looking for fractures and for low bone density when you're diagnosed with hyperpara. I've already mentioned cancer, and there seems to be a slightly higher association with diabetes. So as I said, this slide isn't to scare people, but it's to acknowledge that this is a diagnosis that's important to make and to go looking for any associated problems. And if the patient meets the criteria for treatment, to offer the patient the treatment. And it doesn't mean the patient has to go with that recommendation, but that it should be open. There are loads of problems with these studies and associations. So the amount of risk isn't the same in all studies. It's not the same in all groups of patients. It's not the same in all levels of calcium. It doesn't seem to be predictable. And in medicine, when something kind of goes along with the diagnosis, we call that an association. That's not the same as a cause. So it doesn't mean that hyperpara is directly itself causing all these problems. And of course, that means that treating the hyperpara doesn't necessarily make these things go away. And so we have to bear all that in mind when we're thinking about these associations. So Helen, if you could move it on to the next slide. How do we make the diagnosis then of hyperpara? So the calcium levels in each lab are slightly different, but for us, the upper limit of normal is 2.6 millimoles. And we have a lab adjustment for albumin levels. So you'll hear your doctor talking about this. It's a major protein carried in the blood. Some centres have access to a measurement called ionized calcium, 1.35, and this can sometimes be more accurate when a patient maybe has high normal or only slightly elevated levels of calcium. It can be worth the doctor looking at this. But generally, the recommendations aren't to use ionized calcium all the time because not all labs have a robust way to measure this. So generally, most of the international guidelines look at adjusted total calcium because that's more widely available. And then, of course, we have to measure the parathyroid hormone itself. So normally in patients, this is greater than the upper limit of normal for parathyroid hormone. And sometimes, if you think about it, if this is the major hormone that controls calcium levels and your calcium is high, then this hormone should be suppressed down low. And so if it's in the normal range or slightly high normal, but not yet high, that's also inappropriate and would fit a diagnosis of hyperparathyroidism. We always measure vitamin D because vitamin D deficiency is really, really common. And the natural body response to a low vitamin D level is to put up parathyroid hormone to compensate, because these are the two things that are regulating calcium. So sometimes you'll have a set of blood tests where you kind of go, maybe this is going on, but we'll replace vitamin D and retest before we're secure to make the diagnosis. And it's very important to measure urinary calcium. Now, I'm aware that patients find this a real nuisance. We do a slightly fudge approach to this in some ways by doing a spot urinary calcium, which is like the normal urine spot that you get in if you were testing for an infection, say. And that's because if you have true primary hyperparathyroidism, the calcium in your urine should be either normal or high, because the natural response, again, of the kidneys is to start clearing that calcium out to compensate for the high calcium in the blood. And if it's low, maybe there's another disease condition going on that we're going to talk about. So if your doctor is annoying you to do 24-hour urine collections which we know is kind of challenging for patients to do. There is a reason why they're looking for you to do that. We kind of get two pieces of information for the price of one for doing 24-hour urine collections in primary hyperpara. And the recommendation, again, of most guidelines is to repeat these tests, and not just to do it on one test, and normally to do it 2 weeks apart. For patients who have the sort of milder disease that might later develop into full overt high calcium primary hyperpara, that's called normal calcemic and normal calcium hyperpara. Usually we like to get that result a little wider apart. It's a diagnosis of exclusion because there's lots of other things that might be getting in the way to interfere with making this diagnosis. So the point of this slide is just to show you, we do blood tests, yes, sometimes, and it's appropriate. We need to do these more than once. Sometimes we need to get your vitamin D up and recheck it again. And chasing you to get a urine calcium result is for a reason, and not just to be hounding you and making you do complicated, awkward tests. And another very important thing that even our trainees sometimes get confused about, and I'm not going to encroach on the surgeon's territory here, but parathyroid scans aren't done to make the diagnosis. They're done for planning surgery and the type of surgery you have. The diagnosis is biochemical. It's made on the blood tests and the urine tests. And so that is a very, very important point to make. So Helen, the next slide. So what gets in the way of making this diagnosis? Again, we're often asking people a load of questions in the clinic about other medications and other diseases to make sure that we're making the correct diagnosis. So I've mentioned vitamin D already, but thiazide diuretics lower calcium in the urine, and they raise calcium in the blood, and they're really, really common tablets that are used to manage high blood pressure. So sometimes people will know these as their plus drugs. So they think they're on one tablet, but there might be two hypertension medications in it. One of them is this thiazide diuretic or a type of water tablet. So sometimes we ring a pharmacy and say, can we just check what so-and-so is on? Are they on any thiazides for this reason? And because if we do the urine results, this may mask hyperpara. And kidney disease, of course, if the kidneys aren't able to clear calcium from the blood into urine, that can have an impact. And of course, you can get secondary hyperparathyroid disease in late stage kidney disease, different condition. Dehydration can put people's calcium up, and immobility. If somebody's very sick and is in a high bone turnover state because they're ill for some other reason, it can be awkward to make the diagnosis in that setting. And of course, bone medications. So people who are on treatment for osteoporosis, their parathyroid hormone will often rise in this. Sometimes the calciums can fluctuate just after the medication, so you might miss a slightly high calcium, and sometimes the calcium comes up again before they're due their next dose, and that might make you think they've hyperpara, but they don't. So these are all the things that we're taking into account when we make the diagnosis. Familial hypocalciuric hypercalcemia is a condition that we describe to patients as a bit of a reset. So it's genetic, it runs in families, although there's no reason that you couldn't be the first person in your family with this diagnosis. And it means that the calcium is run slightly high in your blood and low in the urine. And that's one of the reasons why we have to do the urine test to confirm hyperpara. So Helen, the next one. And genetics can help us with this. So about 1 in 10 patients with hyperpara will have a genomic variant, something in their genes that codes their hyperparathyroidism. And medically, we think of this as associated with syndromes like MEN1. So some of you on this call may be living with MEN1, where there are other hormone problems as well as hyperpara, or isolated. So it's just primary hyperpara on its own. And positive genetic results can have an impact on your treatment plan. So the surgery plan might be different. Looking for other problems that you have might be different. Following you up after an operation might be different. So that's why it can be important to do this genetic test. Now, depending on where you live, the indications for testing might be different and the management results vary. So I don't want to say too much about this because it's different in different parts of the country even and in the world. Certainly in my practice, we use a lot of the labs from the genomics testing program in the UK. So what I do aligns with a lot of what's done in England and Scotland. But one important point that the people who study the genetics in hyperpara is that sometimes that urinary calcium clearance can give us a bit of a wrong steer. And I'm just showing these two text boxes. All those little black dots our patients' urine calcium creatinine clearances. And you can see that they're not completely separate, even though one group has a mutation in the sensing receptor, so their calcium runs a little bit high, and the other group don't. So sometimes we have to do these tests, and they take a bit of time to come back. For depending on the lab you send it to, this could take 2 or 3 months. So that does add a bit of a delay into you getting a result back. So just to be aware of that, there's a reason why sometimes we're doing this test, even when we've got a urine result back. Sometimes we just can't call it. So the next slide, Helen, thanks, is when you've made your biochemical diagnosis. In the diagnosis of hyperparathyroidism, we're also looking for the problems that have arisen as a result. And because some people, and you'll all know this, are very well with hyperpara, even when a doctor is a bit worried about them. And some people have what looks on paper like mild disease, but they have complications and they feel unwell. So in the history, you're asked a lot about mood and about acid production. So if you have a history of ulcers, of reflux, of heartburn, if you have a history of depression or low mood, if you're struggling to do things that you might have been doing well 5 or 10 years ago, and usually this would have quite a long history. This isn't something that a switch flicks and is fine one day and terrible the next. But there are medical tests that we have to do as well for these conditions. So we measure kidney function with a blood test, and stones is imaging. I haven't said too much about that because, again, the tests that you have would be different in different centres. So you could have an ultrasound or a CT for kidney stones. Bone mineral density, you'll be familiar with DEXA scanning and looking for fractures. So the picture on the right of the slide here is actually of the DEXA scan of a patient's spine. And you can see we actually got, again, 2 for the price of 1 with this lady. That very dense white blob at the bottom of the picture is actually a massive stone in her kidney that was captured at the time of DEXA. So this woman had primary hyperparathyroidism and low bone density and had stones, which we weren't expecting to find on her DEXA scan. And if you've had a DEXA in the past for osteoporosis, when somebody didn't know you had hyperparathyroidism, they generally just look at your spine and your hip. But with primary hyperpara, we also look at the end of your forearm, so the wrist area, because this is the area that shows the lowest bone density in somebody with hyperpara, and that's because of the effect of the parathyroid hormone on a particular part of bone. So depending again on who you look at and what age group, the prevalence can be up to about 2% of the population, and it's highest in postmenopausal women around the world. Before, everybody used to have symptoms and be struggling with this diagnosis. Now we pick up a lot more just on blood tests. So maybe just under half of people actually have a symptom and are struggling with it. And sometimes we have to go looking for a problem before we know that the hyperpara is causing trouble. So the next slide, Helen. Thanks. So after the diagnosis, and I don't want to encroach on the surgeons, the patients who are very symptomatic and are fit for surgery go for surgical resection. But if they're symptomatic and they're not fit, we have to do things to treat all of those problems that they've run into. And the medical management options are there, but they're a bit limited. So cinacalcet or Mimpra is a tablet that basically fools the body into thinking the calcium is even higher than it is. So it lowers the parathyroid hormone levels and it lowers the blood calcium. And that's effective in up to 3/4 of patients. Sometimes we use that for people when we're trying to see if treating the calcium can make a difference. It's off license. And again, in lots of parts of the world, you're not actually allowed as a doctor to prescribe this to give patients a trial. You know, you get the concept to see if lowering calcium makes them feel better when you're not sure whether the symptoms are due to hyperpara or not. Sometimes in the US, they use the thiazide diuretics after the diagnosis is made to lower calcium in the urine to protect people against stones, but it puts calcium up in the blood. So Irish and UK doctors tend to avoid that as a therapy. You can use bone therapies like alendronate or denosumab that we use for osteoporosis for low bone mineral density. It is effective at treating bone density, but perhaps not as much as if parathyroid is under control. And one thing that patients often ask is, oh, should I stop eating dairy? But that really is not good for the bones, particularly in hyperpara. So you shouldn't limit your calcium intake. We sort out the hyperpara. We don't try and run you calcium deficient to get that right. And we know that there's a little diagram here from a meta-analysis, a study combining lots of studies, that if your vitamin D is low, you should get your vitamin D to normal with supplementation. And that can even lower your parathyroid hormone. It's certainly better for your bones than letting patients with hyperparathyroidism run vitamin D deficient. So the next slide, Helen. Thanks. And this is the last, because I'll be leading into the surgeons then. The so-called asymptomatic patients, the patients that may not feel that they're unwell, that we find the problem, we do recommend surgery to those patients if their calcium is a certain level over the upper limit of normal. So lots of international guidelines will say 0.25 millimoles. In some centres in the UK and Ireland, they say if it's hit 3, which is a little higher than that again. And that's because we think that there's going to be more complications once you hit that higher level of calcium. If you've got a fracture, particularly a fracture of the bones in the back, that would be a recommendation to go for surgery. But if the bone density is particularly low, and this is the score that doctors will use, and we'd recommend surgery for those patients. And actually, bone mineral density responds really quickly after parathyroid surgery. You can see differences within 3 to 6 months after an operation, which isn't the case for all the other complications. If it looks like the kidneys might be being affected by the high calcium in the urine, and that's a recommendation. And one of the reasons why we annoy you to get a 24-hour urine calcium, if you had that, is to see if the level of calcium in your urine over 24 hours is greater than 10 millimoles, because that's an indication. Nephrolithiasis is having kidney stones, which is a grim experience for anybody who's had symptomatic stones. But nephrocalcinosis patients don't know so well. That's when there's tiny little bits of calcium deposited in the kidney, and that can stop the kidney working as it gets worse and as patients get older. And so if they find that on imaging, that's a recommendation. And for young patients who, if they were untreated, would be living with this for a very long time, the recommendation is to treat. So generally, if you have a confirmed biochemical diagnosis of hyperpara, anybody, of course, can be offered surgery. But this group of patients and the symptomatic patients would be the ones where we'd be trying to, shall we say, make a stronger recommendation to go, because they're patients who are more likely to benefit. And you'll see here that there isn't a recommendation to treat patients with mood and psychiatric disorders. And that's because, in spite of quite a bit of research now over the last 10 years, we haven't been able to pinpoint a group of patients that we can tell are going to feel better. And so we know it's not making a difference in large group of patients. I certainly know for individual patients of mine, they have felt way better after an operation, but we just can't pick those patients out and predict them yet. And that's why there's a bit of a gap of evidence to support making a recommendation about mood disorders in this group yet. So I'm going to stop here before I encroach on the surgical time. And thanks, Helen, for moving my slides for me.
Thank you very much, Rachel. That was really interesting. I think will really have helped widen people's understanding, I think, and why certain things are done. I think a lot of us know the basics, but to understand what is behind that is really, really helpful. Thank you. There were quite a few questions ticking up during that. And now we move on to Professor Saba Balsubramanian, please. Thank you very much.
Thank you, Liz. Thank you very much for asking me to come in and talk about surgery. You can see my slides?
Yes.
Yeah, great. Okay, so as Rachel was suggesting, there might be quite a bit of variation in what you know and understand about this condition. So I was struggling with what to cover and how to cover, and I thought maybe I should simply talk about questions, common themes, and issues that are raised by the patients in the clinic when I see them to discuss surgery. So I'll talk about what benefits can patients expect, when is surgery considered to be effective, what are the common tests done prior to surgery, what surgery involves very briefly, and another common question that I get asked, some patients ask, would you be looking at all 4 glands and making a decision, and would rather like you to look at all 4 glands. On the other hand, some patients ask whether a minimally invasive operation or a focused operation would be possible. So I'll talk a little bit about that. So what benefits can I expect? I had a little bit of an introductory slide, which I don't think I need to dwell on. Dr. Crowley has covered all of this quite nicely. So I'll make the assumption that you understand the condition of primary hyperparathyroidism. One of the things that I stress upon when I speak to patients is that this condition may affect one gland in some patients, two in others, three or all four glands. The most common scenario is a single gland problem. We refer to it as single gland disease, and that's the underlying condition in about 80 to 85% of patients. Another thing that patients are often worried about when they first heard the diagnosis is people would have said, oh, there's a growth in your parathyroid gland or a tumor or a mass. And it's important to reassure patients that the vast majority of patients with this condition, with a growth or a mass in one of the parathyroid glands, have a benign, non-cancerous disease. So, what benefits can we expect? Some patients ask, or or they phrase it differently. The key thing really that I say is that we take the enlarged gland or the abnormal gland, and that'll reduce the primary cause of PTH excess and then bring the calciums down to normal range as well. And what does that do? Now, a lot of patients have a number of symptoms that could be attributable to high calciums, but not in all patients. And it's very difficult, as has been suggested before, for clinicians and surgeons to predict which patients will have improvement in symptoms and which patients may, which symptoms might improve. So it's important to keep in mind that symptoms may not improve at all. In some people, a few symptoms might improve. And also the other thing to stress upon is the speed in which symptoms improve is quite variable in my experience. You do occasionally get patients coming to your clinic a few weeks after surgery and say, straight after the operation, I felt a whole lot better. My thinking has sharpened. People say my mood is elevated and so many other things have improved. But in some patients, it can take weeks and months. And obviously, unfortunately, in some patients, symptoms don't improve at all. Now, reducing the calcium and the PTH levels clearly has a beneficial impact on your bone health. There's really good evidence for that. There's also a clear benefit on the risk of stone formation after surgery. So the stones that you might have in your kidneys or the calcium deposits may not, will not go away, but the risk of new stone formation certainly goes down significantly in people who have a successful operation. What about reduced kidney function or renal impairment? Now, the evidence that your renal function will improve is not there. In most patients, renal function remains static. What we can say is that there's some evidence that further deterioration may not occur or may not be as rapid as it could be if you have ongoing disease. And there's a lot of talk about other long-term health benefits. There are lots and lots of papers about potential improvement in cardiovascular health, improvement in blood pressure, improvement in quality of life. And the literature is quite sort of variable, conflicting. And that's why the international guidelines do not place a lot of emphasis on improvement in these other health benefits. Right, so the next question is, when is surgery considered to be effective? Now, Dr. Crowley has already covered the guidelines on when surgery should be recommended. These guidelines have been pulled together by an international group of experts. They updated their guidance last year, 2022, and I've just pasted one of their tables onto the slide. But effectively, what I say to patients is that if there is objective evidence of harm to either the kidneys or bones, then it would be very reasonable to go ahead with an operation. When it comes to kidneys, as has been already suggested, if your urine calcium levels are very high, if your kidney function is low, if you have kidney stones, so you keep forming kidney stones, or there are deposits of calcium in your kidneys, then that's objective evidence of harm from this condition. With the bones, if you have had fractures in your spine, if you've had fractures to other long bones with very minimal trauma, or if you have osteoporosis, which essentially is low bone density, then that's objective evidence of harm from this condition. Now, sometimes there is no objective evidence of harm, but we think that harm is likely to occur. And that would be if your blood calciums are very high, even if you don't have any other problems and you're asymptomatic, if your blood calcium is well over 3, then we believe that you're likely to come to harm, and therefore surgery would be considered to be effective. The other criteria is age. Now, I've got a slight problem with age. So if you look at the evidence on which the threshold of 50 years has been proposed, then that evidence is on very shaky ground. Now, the reason for having a cutoff of having any age threshold is that people believe that if you have asymptomatic disease, or if you haven't had any objective evidence of harm to your kidneys or bones, but if you're fairly young and you have many more years or decades, then it's likely that you will come to harm from the condition. So it isn't completely unreasonable to have some kind of thinking go into how old the patient is. What we don't want to do is offer patients in their elderly patients with lots of other medical conditions. We don't want to subject them to a general anesthetic just because they have a disease. Because if they have mild disease or the calcium levels are not very high, then the risks of surgery may not necessarily outweigh the potential benefits. So that's a reason to think about age. But the threshold of 50 is arbitrary. So we do talk to patients, we do take their age into account, and I wouldn't refuse surgery just because they haven't met the, just on count of this particular criteria. Again, Dr. Crowley has talked about mild hypercalcemia with symptoms. I think there was a question on what is mild hyperparathyroidism. I mean, for me, I would just consider the hypercalcemia as mild simply based on the calcium level. So anything less than 2.85 would be considered mild hypercalcemia. And I think what we do acknowledge is that what might be mild biochemically on the basis of blood tests may not feel mild for patients. Some patients will have quite significant symptoms. And at the end of the day, patients are the best judge of the symptoms. So we recognize that it doesn't help to tell the patient, oh, you've got mild disease. What we say is your calcium is mildly elevated. But we know that the elevation in calcium doesn't necessarily correlate with symptoms. Some people with very high calciums don't have any symptoms. On the other hand, patients with very mild elevation of the calcium can have quite severe symptoms. So it's good to keep that in mind. What we can say is that there is no good evidence that the benefits of surgery will outweigh the risks of surgery and anesthesia in patients without symptoms and who don't meet any of the criteria. So as long as patients are aware of that, and then it is worthwhile then having a discussion about the risks of surgery, the risks of anesthesia, and then deciding on an appropriate course of action. So common tests done before surgery. Now, we often get patients referred from our endocrinology colleagues with all the tests done. Very occasionally, there are some tests that are borderline, and just to be absolutely sure, because we're going to do an operation usually under a general anesthetic, an incision on the neck. So just to be absolutely sure if the levels are borderline or the urine calcium levels results are not entirely clear, we would repeat the blood and urine tests. So it can be frustrating for patients. But what I usually say is that in different hospitals have slightly different ways of checking the urine calcium, and the thresholds might be slightly different. So if your surgeon wants to repeat the blood test, they just want to be absolutely sure, dot the I's and cross the T's, and therefore, of course, ask the question as to whether they've got the blood and urine test done previously, but do keep in mind that sometimes we just like to double check and double confirm the diagnosis. We talk about voice because one of the complications of parathyroid surgery is potential damage to the nerves that supply the voice box. And therefore, if there's any concerns about voice problems before surgery, then we'll look into the voice a little bit more. We might run through a voice score, or we might get a camera check of your voice box before we do the operation. Scans. So once a diagnosis is confirmed or established, as Dr. Crowley said, the scans are not to make the diagnosis. Scans do, however, provide a good roadmap for the surgeon before the operation. As you know, there are 4 parathyroid glands, and we'd like to have some insight into which side the problem could be, and therefore we do scans. Now, again, the kind of scans that are done are very variable from one hospital to another. Even within the UK, there's huge variability. In many centers, 2 scans are done, an ultrasound scan and a radioisotope scan called a MIBI scan. But again, that's not consistent. In some hospitals, they do a 4D CT scan instead of a MIBI scan. And then we usually check the thyroid function. We make sure that the thyroid gland itself is biochemically fine. We don't want to do an operation on the neck around the thyroid gland and then realize after surgery that there might be an issue with the thyroid gland. So the common tests would cover these 4 themes. And then we move on to what does surgery involve. Now, traditionally, and I think I'm referring to perhaps 20 years ago, the common standard operation would be an open incision on the neck and what we would refer to as a bilateral neck exploration. And what that refers to is that we aim to identify all 4 of the parathyroid glands, 2 on each side of the neck, around the thyroid, and looking to see if we can identify these glands and make a judgment on whether they are abnormal or enlarged, and then make a decision on how many glands we need to take out. So that would be the traditional operation. However, just to confuse us, there are lots of other variations to this parathyroid operation. There's a set of operations that could all be classed under the umbrella of minimally invasive parathyroidectomy or limited neck exploration. Now, if I had to go through the various variants of this operation, it will take me an hour and a bit. And therefore, I'd just say that there are so many different variations that are very confusing even for the surgeon, for the surgical trainees. And these variations that fit under the category of, that come under the category of minimally invasive parathyroidectomy would either be minimally invasive because of a smaller incision, or because the surgeons decide to just do one side of the neck as opposed to both sides, or the surgeons might say, I'm only exploring one gland, or sometimes the name is given to operations that doesn't involve a general anesthetic. So there's a lot of there's a lack of clarity in what actually constitutes a minimally invasive parathyroidectomy. So it would be appropriate to ask the surgeon that's proposing a minimally invasive operation, what he or she actually is referring to. Finally, the question about should all glands be assessed at surgery? It really depends. It depends on what the likelihood is of you having a single gland as the cause of your disease. It can be difficult to predict who has single gland disease and who has multi-gland disease, but we're often guided by the results of the scans you have before surgery. Like I mentioned before, about 80 to 85% of patients who come with a diagnosis of primary HPT who've not had an operation before have single gland disease. And often this is clear on the scans that are being performed before surgery. It also depends on whether what the likelihood is of having an inherited or familial component to your disease. What's the possibility of genetically predetermined disease? And that's partly dependent on how young the patient is. And finally, different, like I said before, different surgeons have different practices based on what's available locally and how they've been trained. And like physicians, it's difficult in surgical practice to have uniformity of practice. People do things differently, and that's how they've always done. And if they do it their way, then the success rates might be high. So surgeons use different aids during surgery. Some surgeons would often always use what we call a frozen section examination to check if the structure they've removed is indeed a parathyroid gland. Some surgeons would almost always check blood PTH levels during surgery to check if the PTH levels have dropped, and then they will say the PTH levels have dropped satisfactorily, and therefore I'm not going to look at the other glands. And there are all sorts of new technologies that are increasingly being used in the operating room, such as fluorescent guided surgery and so on and so forth. So the answer to this question is not straightforward, but it can be straightforward for the individual patient based on their specific set of circumstances. So certainly a question worth asking, but just to be aware that no one size fits all. I'll stop there. Thank you very much again to Liz and organizers. Liz and Parathyroid UK have helped us hugely in doing some research around parathyroid glands in hypo and hyperparathyroidism. So I'm ever grateful for that. Thank you.
Thanks very much, Saba. That was really interesting. I just think it's so helpful for patients to be able to have a presentation like this geared specifically to them with advice such as ask your surgeon, talk to your surgeon, what are they referring to? Thank you very much. Lots of questions creeping up as well. And now we move on to Mr. Radu Mihai, please. Thank you very much. We can't hear you, Radu.
Good evening, and thank you very much for inviting me. Is all clear now?
Yes.
Where we can start. Maybe being the last, I will repeat some of the comments made by my colleagues, but it's never too much. And so we better go through the information more than one occasion to see that from different perspectives, we all think along the same lines. So no conflicts. Overall, there is a debate of who exactly it's operated, and one of the questions was how common is this condition, because in a large trust of the land covering 1 million population, apparently they only do 50 operations a year. 50 is not bad, considering that we hoped to stop colleagues doing maybe less than 10 or 20 a year. So it's only a small percentage of the patients with the condition that gets operated, those who are more obvious, either that present extremely young, which is most unusual. This is a case of a 15-year-old girl with renal colic, or with convincing multi-gland disease, or with renal stones or osteoporosis. But there is a large majority of patients that remain undiagnosed, and some that are diagnosed, but the benefits of an operation are debated, and so they never proceed through the process. And so operations are not as common as the disease is in the public, and that should not surprise. At times, the indication is very clear, because if you present with extremely high calcium, it's an emergency, and that will be dealt with at times in the same admission that reach the medical diagnosis. And so in recent years, we had quite a few patients presenting just like that. If we are more commonly to follow the NICE guidelines, they put this number of 285 on the hypercalcemia as a potential restriction or gate, but we know that in reality many patients are operating when they are under that threshold, and so that in itself it's in no way a limitation of our practice created by NICE, but it tries to give you some sort of way to stratify the risks versus the benefits, as it was mentioned a bit earlier. There are some that come with an expectation of an operation because they are chasing the bone strength, or they hope to see this symptomatic improvement, that it's very impressive when it happens, but can be very disappointing if it doesn't occur, despite the blood test returning to normal. and the patient feeling no different. And then is this mismatch between the hopes that were raised before an operation and the reality after the operation. And very rarely we get to see patients with familial disease. They would arrive already very informed of their condition because many members in their own family would have been through the process, and maybe by now they know the pitfalls and the distress that at times such operations can bring. I wanted to touch, and it's interesting, already my colleagues mentioned, because when I started, it looked like life was a lot easier some 20 years ago. There were normal patients and patients with primary HPT, and there was a clear mark between them. And we were only stratifying the severity of primary HPT. And maybe for the last decade, this concept has slowly increased in the conversation, this normocalcemic hyperparathyroidism, where many patients have either the calcium or the PTH in the normal range, but the other one is abnormal. They present with disproportionate symptoms compared with the biochemistry, and yet they hope to see the improvement that is being reported for what is called now classical HPT. So this is a field of debate. It's a field that needs more work done to understand who would be the ones who really benefit. And what is worrisome from the point of view of the profession, but very important from the point of view of patients, is that this normocalcemic has increased in size in my perception. I'm seeing less and less severe hypercalcemics, and I struggle to know how to advise patients with normal blood results, but symptoms that match the classical description of primary HPT, and they come already with an expectation that, in my view, is disproportionate with what an operation can offer them. But whatever how you end up having an operation, I was asked to comment what could go wrong with an operation, because the current consenting rules of the land suggest that we should discuss everything that can be life-changing, whatever how rare the incident could be. Well, it's not rare, and but it's not as common as after thyroid surgery to have voice or swallowing problems. You expect this to be temporary. The risk of injuring the recurrent nerve are certainly that bit lower than during a thyroid operation. It's a lot more handling of the nerve, and most of the time with the parathyroid, this is not the concern. But nevertheless, whatever how good the nerve function is, whatever how much reassurance we give ourselves as surgeons, and then pass it on to the patient that the intraoperative nerve monitoring shows normal function, those who are very musical or who are very much professional users of their voice, not just for social reasons, would be aware of some changes. Hypoparathyroidism, it's important to mention here because, as we heard at the beginning, the society started as a group of patients distressed by a lack of parathyroid function, and now it's extending support towards those with an excessive parathyroid function. And I tell my patient that life is a lot worse with no parathyroid than whatever how bad it is with too much parathyroid. So I fear that in the current context that was mentioned by my colleague of removing more than one gland, and of patients coming already questioning whether all the glands will be inspected, if too many glands are visualized, where, irrespective of the findings on the scans, a temptation will be to remove more than one gland. And I fear 5-10 years from now, if this trend continues, the hypopara arm of the society will be stronger than the hyperpara. And that is not right, because that will be disease induced by us, somehow triggered by the patient's expectations that all glands would be removed, visualized. But what I'm here to talk, it's about the failure, because failure, it's for this operation something extremely frustrating for the surgeon, and very much a problem difficult to be understood by patients. Because for no other operations that we do, you can wake up a patient and say, I'm very sorry, I didn't find the organ that I was supposed to remove. If you come with colon cancer, with breast cancer, with kidney cancer, with any other operation that it's supposed to be affecting an organ, you can't say I didn't find the stomach, but you could end up having to recognize that you didn't find the enlarged parathyroid. So failure, it's part of this operation. And I would say that everybody fails. And if you practice long enough, before you retire, you'll have the memory of the cases that really distressed you. So it's not that nobody fails. The question is how common is failure. So the audit maintained by the British Association of Endocrine Surgeons records currently about 4,000 operations. Of those, about 2/3 of patients who have positive scans end up having only a limited exploration because people feel very much in need to reassure themselves that there would be no failure by misrecognizing overactive glands. And even in this context, the failure is about 5%. And this takes you back to numbers. So you do 100 cases, you miss 5. You do 10 cases, well, it's difficult because if you're unlucky and you miss 2 or 3 in these 10 cases because so it happened to be the nature of the disease that you try to deal, all of a sudden you're off the scale with your failure rate, and it will take few years until you recover. So my view is that a large volume practice brings the experience, but also brings a chance to dilute the negative results in the mix of many others that have been straightforward and with the expected positive outcome that the patient and the surgeon hopes at the beginning of the operation, but is missing sometime at the end of the operation. So why do we fail? Well, because sometimes the gland is in the wrong position and it's called ectopic, or it's an incomplete resection of the abnormal glands. That's the reason why people expect to visualize more than one that's been picked up on the scan. A missed adenoma, it's a really bad advert for the practice because it means you removed something that you expected to be a parathyroid and in fact was a lymph node or a thyroid nodule. It's very rare to be the regrowth of a tumor that you excised in the past. And this debate has been influenced by James Norman, who was a very famous parathyroid surgeon in the United States in an institute that does about 2,000 operations per year, very expensive to be admitted under his care. And after he looked at about 20,000, 15,000 patients, he said that some 10 years after the operation, there was a failure rate of about 5%. And so he wanted now to introduce bilateral neck exploration in everybody. Well, because of these concerns, I looked at our own practice and I looked at the patients initially operated by Greg Sadler and then together when I joined him, and I allowed a long follow-up for this cohort, up to 10 years of them. And indeed, some 10 years later, there were a number of failures and not everybody was still normocalcemic. But when I looked at who failed, and there are about more than 10 such patients, the time to recurrence when they needed a second operation was in excess of 6, 8, 10 years, which means, in my view, that at the time of the initial operation, nobody would have identified the gland that would give them problems some 10 years later. And therefore, in this context, I said that in selected cases where the biochemistry, radiology, and intraoperative findings make sense, focused parathyroidectomy should not be completely excluded, even in today's practice. But this is an area that's going to change in coming years and is very much influenced both by the patients and by the surgeons' confidence or experience or ability to address the concern raised by those patients who are a bit more willing to explore on their own the theory of this operation before coming to have it done. So what I tell the colleagues who train before they go ahead to practice on their own is that this variability in experience creates slight confusion currently in the training of the juniors to try to understand how you avoid this persistent disease. And this is something that our profession will need to address in coming years to make it a bit more consistent in the approach. So I will jump over this, but the question is, because some of you might experience this problem of a failed parathyroidectomy, what to expect after a failed parathyroidectomy? Well, first of all, I say my trainees don't raise false expectations, because if somebody failed, there's no guarantee that you will succeed at the second operation. Don't make any negative comments about the first surgeon, because that person started with all the goodwill and all the information available at the time and didn't fail of his or her choice. failed because so it happened on the day. You can't make promises based on what the literature has described. If the best hospital of the world publishes a certain percentage success for redo parathyroids, that might not be replicated in every other unit of the world. And don't plan a redo operation without positive scans. In fact, there was a question that I quickly read while I was listening to the others, where somebody who did have a failed operation now has negative scans and nobody offers a second operation. And I quite agree with that approach, frustrating as it sounds. Because I think once somebody or yourself has failed, you need imaging to drive you to the missed gland. And those techniques, with no reason to go in the detail of each of them, come in layers. I put them in a traffic light system because some are commonly available in any hospital of this country, like a repeat ultrasound and the system EB. But it's not available everywhere to have this 4D CT scan that was mentioned by my colleague, or the old-fashioned PTH venous sampling that it's not that much in use these days, but in the past was the only one to have. And very few hospitals will have access to this new tracer called PET choline that is available, and it's supposed to be effective in people who failed. We published the first experience of about 18 patients, but now it's been replicated in many other hospitals in the UK. And the last tracer there, this C11 methionine, it's only available in Cambridge on a very intermittent base. And myself, I did not manage to have any patients scanned there, but I know there is one such tracer that maybe in coming years will be more available. So failed parathyroidectomy, it's a minefield. It's most likely frustrating to the extreme compared to the first operation. And for that reason, it should be based on resources that are not easy to have in every center. And therefore, the expertise for such cases should be centralized across the country, and patients should agree to travel despite the inconvenience. So I think negative scans might be more debatable, but would be better to limit the number of people who operate on patients with negative scans at the time of the first operation. Patients with familial primary hyperparathyroidism should be seen in big centers where genetics and multidisciplinary input is easily available. And those with recurrent or persistent disease should again be seen in few hospitals of the country, because the technology cannot be made available in every single other hospital. So this is my take on this question that was raised about what can go wrong and what happens if it fails at the first attempt. You will be pleased to know from a patient perspective that the government is really trying to make this delivery of service that bit more effective. And Professor John Walsh, Professor of Endocrinology in Oxford, and Mr. Lansdowne, former president of BATS and retired consultant surgeon in Leeds, have led this sort of review of practice and facilities available in many hospitals in the country, and generated some guidance that hopefully in coming years will have to be somehow implemented. So potentially in few years' time, if we have the same webinar, the service provision will be better. But currently, I try to describe the questions that we as surgeons might have and the frustrations that you as patients might experience. I'll wait for questions. Thank you very much.
Thank you very much indeed, Radu. That was very interesting to hear about the difficulty from the surgeon point of view, which I don't think probably any of us have ever heard before. I do agree with the expertise being focused in regional centres as well. I do think that will be very important. And the GERFT programme has been really interesting. I don't know if you saw our national audit that we did last year on hospitals straight after surgery, post-op. That's something we look into later on. Anyway, questions? I think we'll stay with the surgical questions for the moment, and Helen will also be looking through the ever-growing list down the bottom here. A lot of this you've covered actually already, which is fantastic. In particular, there were questions about redo operations. Do you recommend all remaining glands being checked? And our imaging, which you've also touched on, are images required before redo surgery?
Yeah, I agree with what Radu has said. I think he's answered the question. So I think that the 2 or 3 questions on that. So if surgery has failed, if the surgeon is proposing or considering a second operation, re-exploration, then most of us would require scans, imaging to identify a target before we re-explore. I mean, there are some rare exceptions, but as a general rule, re-exploratory surgery is not considered in patients where scans haven't given us a clue. The first time operation is different. The first time operation, there's no scarring in the neck, and the scans don't have to necessarily pinpoint a target for the surgeon. And the surgeon can then do a bilateral exploration and look for all 4 glands and then make a decision. But if patients have already had surgery, then the area is quite scarred, and you don't want the surgeon to go into a scarred field looking for glands that haven't been identified before surgery because of the high risk of damage to the nerves and damage to normal parathyroid glands.
Thank you. You've touched on how to avoid hyperparathyroidism, but how many operations should a surgeon be doing a year in your view?
Oh, I'll try to answer this. This is not an easy answer. The European Society tried to look exactly at this work volume and outcome correlation, and through some sort of interpretation of the data, I came back as a number 20 per year. And it's not easy to prove that 25 is better than 18, but certainly aiming towards that sort of number. On the other hand, many surgeons of this country, based on the geography and the distance to travel and so on, have a practice that will not allow them to have more than 20 parathyroids a year. And if those people would stop, it's true, other surgeons will have much more done in a year, but many patients will travel much more too. And so it's not an easy balance to impose, because just as much as those who failed say, oh, why did I been operated by somebody who does less than 20? So frustrated also would be patients who get a successful operation, but having traveled 3-4 hours in a car. And they would say, why on earth did I have to do all of these journeys? And for the scan, for the pre-op assessment, for the surgery, and so on. So how to keep everybody happy is not easy, but ideally 20, it's a landmark. Those who push it and say, oh no, you should do 50, oh no, you should do 100. Well, then I don't know how many people are doing 100 in this country every year. Well, probably less than 10 will do 100. And so you cannot have the whole country going to those 5-10 people. And so we need to interpret this number with caution and seeing it from both perspectives. But 20 is the number that GERF tries to promote.
Thank you. Tricky one here. What to do if the GP refuses to do post-op follow-up of blood tests? In some practices, they're no longer accepting requests from hospitals to do blood tests.
This is a political question. We had it in our own region, and we understand that it's about how money flow and how the contracts are being debated, and it's not expensive test to do a calcium, and the PTH is probably certainly under £10 for the GP, but it's just the logistics of organizing it and moving it around. So I think it's the responsibility of the operating unit to provide the first level of follow-up, and then I expect in the current political climate, the interaction with the GP practices, with the big hospitals, with the public, probably will change in the coming years. But currently there is a tension based on the way the contracts are set up.
Can I ask, just in addition to that, Liz, there's another question that said, how often should bloods be checked post-op? So I think that kind of links with that question.
So after a successful operation, we would usually advise GPs. So we see patients once after the surgery, at least once, sometimes more than once. And if the calcium and parathyroid levels have normalized and there are no surgical issues, then we usually ask the GPs to check the calcium at 6 months and then annually. Some patients can have recurrence years down the line. So annual follow-up is what we'd advise in our discharge letter. And usually just the calciums would be fine. But Dr. Crowley probably can add to that.
Yes, I mean, there's going to be cases of people in this particular webinar who are living with more complicated disease often, and that's why you're here. And for many patients, they are cured as defined by having a normal calcium after surgery at 6 months and do well after that, and don't get a recurrence. Sometimes there are clues. There are certain patients where there are clues at the surgery or how long it's taken for their calcium to drop where we might advise keeping a closer eye. So it's a slightly individualized question.
Thank you.
Thank you.
And how soon after surgery should you request a repeat DEXA or bone scan to see if osteopenia or osteoporosis has improved?
So depending on the series you look at, you can see differences as early as 3 months, but I think that's way too early to go looking for a change. So I think it's reasonable to do it a year after. And now, of course, a lot of what we're talking about here, it's been very obvious to me looking at questions and listening to talks, is if you had the ideal access to resources and everybody got access, but there are queues for all of these tests. And that's what's limiting people getting to surgery as well. There are wait lists. Most of our wait lists after a decision has been made to operate are at a year or more. So that's also true for follow-up tests. I don't think it's problematic, particularly if somebody is not actively fracturing, if their DEXA is a little bit more than a year after.
Thank you. There are several questions, Rachel, about watch and wait. So,
yes.
Maybe we should just ask you what the rationale is for that.
So, yeah, so I saw somebody ask very early on what the definition of mild is. And so let's go right back to the people with the disease that's picked up because either another doctor or a GP has done what are called routine tests. So these are patients who don't have any symptoms at all, but somebody has picked up a calcium and a PTH that are elevated. And these are the people that sit in my clinic going, I don't know what an endocrinologist is, and I don't know why I'm here. And so those people have mild disease, and they're people that you might find something like a kidney stone they didn't know they had, or a kidney function that's deteriorating. And we're saying to them, actually, I think this is more of a serious condition that it might have looked at first glance, so to speak. So there are people who might be in a watch and wait scenario. This is a difficult concept because there are some things that very obviously a patient is going to get benefit from. So if they have kidney stones, if they have deteriorating renal function, if their calcium is very high, if they have one of the more severe psychiatric manifestations of hyperpara, then, as both of the surgeons and myself have said, those symptomatic people we recommend for surgery, and ideally, actually, to be honest with you, they would get bumped up the list and not waiting the year if we can possibly do it. So we often do slightly, in some ways, cheating things that they've come in on a medical admission and they go out from a surgical admission because we try to use the bed and get them sorted while they're in. And then there are a load of people in between where it's not clear what the benefit of an operation is going to be. So some people will just say, I want to have an operation. I can think very clearly of 2 patients I have seen who had complications of parathyroid surgery that made me kind of go, oh, should we have sent that person for an operation? But they did feel remarkably better after the surgery and said they'd rather have the complication than what the hyperpara was beforehand. And that's why people have done so much research in the mood and the neuropsychiatric side of things, because we know there are individual patients who get a lot of benefit, even when it didn't look like they would before the surgery. But we just still can't pick those people out. For the other people with the watch and wait, that's why we do all these tests on the so-called asymptomatic patients, the patients who don't have these more dramatic, like the more old school idea of what hyperpara look like that Radu was talking about. So they may have more, they may be symptomatic, but it might be more subtle, and we have to go and look, because having a DEXA with a low BMD, that's not symptomatic. That's not a patient who's fracturing, but they might still have significant bone disease. Somebody asked, I saw in the questions, about how could you not treat osteoporosis? Sometimes that's because you can't be sure it's osteoporosis related to hyperpara. Osteoporosis is very, very common. And lots of people have it who don't have any problem with their parathyroid glands. Somebody asked, how would you know if it was to do with the hyperpara? If I saw a pattern where it was really affecting that end of the forearm, that area near the wrist, and it was worse there than the other parts, I'd be more convinced that that was related to their parathyroid disease. And that would push me more for thinking it's not just a bystander. I mean, these are all the considerations that we take in mind when we're sitting across from a patient who either feels totally fine, but I'm worried about a test result that makes me think they're in more trouble than they think, or that they don't feel very well, even though their blood tests or urine tests on paper don't look as severe as another case. There's a really wide spectrum with this. That's why we're trying to do research and find out more than we know at present about it.
Thank you. That's brilliant. And leading on from that, how can patients manage their symptoms while they're waiting for diagnosis or surgery?
Oh, that's so tough. Okay, I will be absolutely blunt here. There is a culture now in wellness and in the literature of making people feel sometimes that they've either done something wrong that's brought a disease on, or that there's something they can do to make it go away outside of medicine. And in a lot of conditions, that is really unfair. I mean, people haven't done something to bring this on themselves, hyperpara, primary hyperpara, and they have a certain degree of control, but not a lot. So I would think, you know, most places can do an assessment of your calcium to see how much you're getting in your diet and tell you if you're under or overdoing it. Somebody was asking about calcium supplementation. If you're getting enough calcium in your diet, you don't need supplements. And it's a safer way to get it, because calcium supplements are associated with kidney stones in patients who don't have hyperpara. And making sure that you, if you need it, that you take vitamin D during the winter months. And those 2 things will help protect your bones. Somebody was asking about exercise, and I think very reasonable to walk and do some resistance work to load your bones. It's not going to completely offset hyperparathyroidism, but it's helpful. And staying well hydrated. I mean, in Ireland, we've experienced some very hot weather in the last month, and staying well hydrated in hot weather is important, particularly for people who are at risk of stones. And if you're sick for another reason, making sure that you keep up your fluid intake is important. Some people with more, usually, but not necessarily with higher levels of calcium, can get a lot of acid production and need sometimes quite high doses of antacid medications to control that. And we do notice that after a parathyroid surgery, that might not normalize, but their requirements might drop. These are all things to think about. But you're not in control of the overall disease, and it's not fair on you to suggest that you are. I think that's burdensome to people.
Thank you very much. Yes. And a last one for the surgeons. After removal of 3.5 glands in hyperplasia, what is the evidence for how long the remaining half gland might survive?
Well, maybe both of us will make a comment. Might survive. The hope is that it will survive forever. And this is why I was saying earlier that I fear that after this bilateral neck explorations with multi-gland excisions based on macroscopic appearance. There is a danger that some patients will end up hypopara, because leaving half a gland behind just based on macroscopic decision, it's never a guarantee that it will work. The new techniques with this fluorescent imaging that Professor Balsubramanian is running a trial on might bring a layer of reassurance that you can prove that the fragment you left behind is vascularized and alive at the end of the procedure. But nevertheless, 3.5 glands excision in somebody who is not MEN1 patient, I think it's an excessive operation and is not to be encouraged.
Thank you.
Saba, would you agree?
Yeah, I agree. If someone's asked how long they'd survive, like Radu said, you'll know straight away whether the parathyroid levels are fine or not straight after the operation. And the levels are fine, then they should be fine. They will survive. I don't know if the question was meaning to ask, could the remnant also become hyperplastic? I think there was some question along those lines. Yes, that could happen, and occasionally, especially in MEN1, as Radu has pointed out, that itself, the remnant could become problematic and could cause recurrence of the primary hyperparathyroidism. And occasionally we might have to go back to sort that remnant out. I hope that answers the question.
Yes, thank you. And a final one for Rachel. When does an endocrinologist offer sinacalcet? And should we all be on it if our calcium levels are high?
So this massively, again, is a political thing and about reimbursement in different places. So because I practice in Ireland, I'm not restricted in when I can decide to give sinacalcet. So the situations in which I use it is if a patient would meet the criteria for surgery because of very high calcium levels but isn't fit. So I work in a centre where we have a lot of we've one of the oldest patient catchment areas in the country. So we sometimes have very elderly, frail patients who just would not be fit to have an operation. But their calciums could be 3.4 or 5. They're getting dehydrated. They're getting delirium in hospital, and we would offer those sinacalcet. There's the odd patient I mentioned this where you might try sinacalcet for a short space of time because they don't meet other criteria and you want to see if lowering their calcium makes them feel better. So that is another option. We sometimes use it because, as I've already mentioned, there's very long wait to surgery and patients feel unwell. It's important to note that sinacalcet doesn't help your bones and it doesn't prevent you getting stoned, or at least for the moment, the evidence suggests that it doesn't do that. So you have to know what you're using it for. And I do get some patients who really can't take it. So, you know, you've tried it, but they feel awful on it. It can cause a lot of GI upset. It's expensive. That's why it's not reimbursed for these uses everywhere. So it does depend a little bit on where you live, what your access is, what the situation is, what your surgical plan is and your time to surgery, all of those considerations.
Okay, thank you very much. Right, that's all my questions. Helen, is there anything left on the chat before we
I think
run well over time, I'm afraid.
Yeah, I was going to say we probably need to wrap up, but any of those questions that are left, I think so many have been answered already, so I will export those.
And thank you very much, the doctors who I see have been stepping away answering questions as well, so that's brilliant.
Yeah, it's been really good, thank you.
So
thank you for inviting us.
Thank you all very much.
Thank you.
Thank you very much indeed.
Thank you, everyone.
Bye,
Have a good rest of the evening.
Thank you.
Bye.
Bye.
Bye-bye.